So my suggestion is learn from Devin. Don't cheat.
I didn't know.
Yeah.
All right. We're gonna learn tonight about what killed 1 out of every 2.3 Americans because of our high style living. The cheeseburger, pizza, and barstool lifestyle. Hot wing Sundays. Preparedness is everything. If you're not prepared, the government can shut down and you won't be able to get your certs.
But I can find it.
Right, but if you were prepared, it would have been a lot easier.
I'm done. I mean, I did.
You have to make a split-second decision. You have to know that your equipment's ready to go. You have to know how to use it. You know what to do without thinking about it. It has to be automatic. The only way it's automatic is if you are prepared. Everybody can talk. I'm not gonna go there right here. Okay. Talking and dreaming is easy. Action is what makes things happen. Action is what makes a difference. Anybody can talk about this. Very few can do it. Any questions? All right. Objectives. You're going to understand the basic anatomy and physiology of the cardiovascular system. Something I've been trying to teach you guys since the first night that some of you are still struggling on. We're going to go to the anatomy and physiology. We're going to learn about angina pectoris, thrombolism, myocardial infarction, hypertension, aortic aneurysm, and aortic dissection. There will be lots of test questions on this because I put together a whole bunch of cardiac test questions. This is what kills like 1 in 2.5 people. So it's very important to know. We're going to go over it in detail. We're going to go over We're going to discuss and identify the anatomy and pathophysiology of the parent. We already went over this. Any questions? I think I already did that slide. We're going to go over why AEDs are important, how it works. We're going to go over why it's important to get advanced life support rolling as soon as possible. It's truly a cardiac emergency. It's one of the few things paramedics are actually good for. Any questions? All right. Cardiovascular disease kills about 2,500 people a day, every day. That's about a person every 30 seconds. Pretty cool, huh? There goes. Any questions? You need to know the blood flow through the heart. The oxygenated blood leaves your cells to the venous system, goes to a vena cava, either the superior or the inferior, depending on if it's above or below the heart, which goes to your right atrium, which goes to your tricuspid valve, which goes to your right ventricle, which goes through your pulmonary valve, to your pulmonary artery, to go to the lungs, to exchange oxygen and carbon dioxide, to return from the left atrium to the pulmonary vein, to the left ventricle, to the left atrium, through the mitral valve to the left ventricle, through the aortic valve to the aorta, and back up to the arteries to the cells. Any questions?
I have a heart attack just saying. Yeah, breathe.
Now here's something we hope you'll really like.
Is one of the most amazing organs in your body. This is the human heart, and it's shown with all the vessels on it, and you can see the vessels coming in.
That's the same voice as the guy that narrates the old man rolling away on the hearing.
Yeah.
It's the same voice. I swear.
To it and out of it. But the heart at its core is a pump, and this pump is why we call it the hardest working organ in our body, because it starts pumping blood from the point where you're a little fetus, maybe about 8 weeks old, all the way until the point where you die. And so this organ, I think it'd be really cool to look at in a little bit more detail, but it's hard to do that looking just at the outside. So what I did is I actually drew what it might look like on the inside. So let me actually just show you that now, and we'll follow the path of blood through the heart using this diagram. Let me start with with a little picture in the corner. So let's say we have a person here, and this is their face, this is their neck. I'm going to draw their arms, and they have in the middle of their chest their heart. And so the whole goal is to make sure that blood from all parts of their body, including their legs, can make its way back to the heart, first of all, and then get pumped back out to the body. So blood is going to come up from this arm, let's say, and dump into there, and the same on this side. And it's going to come from their head. And all three sources, the two arms and the head, are going to come together into one big vein. And that's going to be dumping into the top of the heart. And then separately, you've got veins from the legs meeting up with veins from the belly, coming into another opening into the heart. So that's how the blood gets back to the heart. And anytime I mention the word vein, I just want you to make sure you think of blood going towards the heart. Towards the heart. Now, if blood is going towards the heart, then after the blood is pumped by the heart, it's going to have to go out to the heart, right? It's going to have to go away from the heart. So that's the aorta. And the aorta actually has a little arch like that, and we call it the aortic arch. And it sends off one vessel to the arm, one vessel up this way, a vessel over this way, and then this arch kind of goes down, 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 and splits like that. So this is kind of a simplified version of it, but you can see how there are definitely some parallels between how the veins and the arteries are set up. And arteries, so anytime I mention the word artery, I want you to think of blood going away from the heart. And an easy way to remember that is that they both start with the letter A. So going to our big diagram now, we can see that blood coming in this way and blood coming in this way is ending up at the same spot. It's going to end up at the, actually maybe I'll draw it here, is ending up at the right atrium. Right atrium. That's just the name of the chamber that the blood ends up in. And it came into the right atrium from a giant vessel up top called the superior vena cava. And this is a vein, of course, because it's bringing blood towards the heart. And down here, the inferior vena cava. Inferior vena cava. So these are the two directions that blood is going to be flowing. And once blood is in the right atrium, it's going to head down into the right ventricle. So this is the right ventricle down here. This is the second chamber of the heart. And it gets there by passing through a valve. And this valve and all valves in the heart are basically there to keep blood moving in the right direction. So it doesn't go in the backwards direction. So this valve is called the tricuspid valve. Tricuspid valve. And it's called that because it's basically got three little flaps. That's why they call it tri. And I know you can only see two in my drawing, and that's just because my drawing is not perfect. And it's hard to show kind of a flap coming out at you, but you can imagine it. So blood goes into the right ventricle, and where does it go next? Well, after that, it's going to go this way. It's going to go into this vessel, and it's going to split. But before it goes there, it has to pass through another valve. So this is a valve right here called a pulmonary valve. Pulmonary valve. And it gives you a clue as to where things are going to go next, right? Because the word pulmonary means lungs. And so if this is my lung on this side, this is my left lung, and this is my right lung on this side, then these vessels, and I'll let you try to guess what they would be called. These vessels, this would be my, make sure I get my right and left straight. This is my left pulmonary artery. And I hesitated there just to make sure you got that because it's taking blood away from the heart. And this is my right pulmonary artery. So this is my right and left pulmonary artery. And so blood goes now into my lungs, right? These are the lungs that are kind of nestled into my thorax where my heart is sitting. Goes into my lungs. And remember, this blood is blue. Why is it blue? Well, it's blue because it doesn't have very much oxygen. And so one thing that I need to pick up is oxygen. And so that's one thing that the lungs are going to help me pick up. And I'm going to write O2 for oxygen. And it's also blue, and that reminds us that it's full of carbon dioxide. It's full of waste because it's coming from the body, right? And the body's made a lot of carbon dioxide that it's trying to get rid of. So in the lungs, you get rid of your carbon dioxide and you pick up oxygen. So that's why I switch at this point from a blue colored vessel to a red colored vessel. So now blood comes back in this way, and dumps into this chamber. So what is that? This is our left atrium, So just like our right atrium, we have one on the left. And it goes down into, and you can probably guess what this one is called, it's our left ventricle. So just like before, where it went from the right atrium to the right ventricle, now we're going from the left atrium to the left ventricle. And it passes through a valve here, right? So this valve is called the mitral valve. And its job is, of course, to make sure that blood does not go from the left ventricle back to the left atrium by accident. It wants to make sure that there's forward flow. And then the final valve, I have to find a nice spot to write it, maybe right here. This final valve that it passes through is called the aortic valve. And the aortic valve is going to be what divides the left ventricle from this giant vessel that we talked about earlier. And this is, of course, the aorta. This is my aorta. So now blood is going to go through the aorta to the rest of the body. So you can see how blood now flows from the body into the 4 chambers. First into the right atrium. This is chamber number 1. And then it goes into the right ventricle. This is chamber number 2. It goes to the lungs and then back out to the left atrium. So this is chamber number 3, and then the left ventricle. And this happens every moment of every day. Every time you hear your heart beating, this process is going on.
Any questions? All right. So the electrical system of the heart. Let's go over it. So if you remember, we talked about the heart. Every cardiac cell has a special property called automaticity. The automaticity means it can create its own electrical power plant. Yeah, I know that's about it. It's not real. We're trying to make things better. So you got the right atrium, right ventricle, left atrium, left ventricle. Blood comes in, right atrium goes down right ventricle, goes to the lungs, comes back left atrium, left ventricle, that's the aorta, for the rest of the body, right? Now, how does it pump? So the way it pumps is it's kind of like binary numerication, computer, cell phones, how that works. So it's all repolarization and depolarization. So it starts in your SA node. Your SA node is in the right atrium, and that is the pacemaker of your heart. That will be the test question. When the SA node depolarizes, it sends a chain reaction of depolarization down a pathway to the AV junction. And the AV junction sends out a whole bunch of pathways down 2 different bundles, one down to the left ventricle and one to the right ventricle. On the bundle it hits, they depolarize until they get to the ventricles. The ventricles all depolarize at the same time. Meanwhile, at the top of the SA node goes the atriums. They depolarize first, which sends blood down to the ventricles to the valves. Then when the ventricles compress, they send blood to the lungs and the rest of the body. Then it all has to repolarize again, so it can start over again. Anybody ever play with dominoes? If they knock dominoes over, how big a depolarization is a set of dominoes. So think of it as the same as being the first domino you knocked over, and it knocks down dominoes. Look, it's the AV junction, it's got a ruler, then knocks down a whole bunch more dominoes. Then somebody's got to go through to reset all those dominoes. Make sense? Now, Dr. Zoll, I don't know, maybe 100 years ago, put his wife in a bathtub full of salt water They put alligator clips on her and wanted to have a theory about that. I don't know how he came with that theory, but he did. That you could actually watch the depolarization if you had electrodes on the limbs. And so what that does, it gives you an EKG. So when the SA node depolarizes, you get a P wave. Then there's like a little pause until it goes down the bundle of his from the AV junction. Then as the ventricles depolarize, you get that telltale EKG sign. So you can see those side ambulances and stuff. And then as it all repolarizes, you get another big bump like that. That's what that is. That's a node depolarizing, ventricles depolarizing, somebody resetting all the dominoes. Make sense? So that's all fine and dandy. Until it doesn't work right. It's important to know that for your EKGs. I'll look at that just over right now. So where the problem is when the left ventricle contracts, it goes out the aorta. And the first artery out the aorta, which will also be a test question, is your coronary artery. The heart perfuses itself first. So if your coronary arteries start to get plugged up with plaque from all those pizzas and cheeseburgers and hot wings you're watching on Sunday while you're not exercising, you get reduced blood flow to the ventricles. So no big deal until you try to walk up a staircase or do extra exertion, try to open a roof with an axe. And then what happens is your ventricles know it's not getting enough blood, so they think the SA node's not doing the job. Now, one of the cool things about automaticity is that the SA node dies or just decides to quit its job, any cell in the heart can take over as the pacemaker, but they're not as effective. So like the AV junction, so the SA node goes like 60 to 100 a minute. You can fire it like 60 to 100 times a minute. AV node can only do about 40 to 60. And the ventricles, they can do it if they have to, but they're usually 40 or less. But what will happen is if they're getting lack of blood flow, they're getting irritated, they'll try to take over as the leader. So they'll depolarize before the SA node does. So when it does that, that sends the dominoes backwards. So then the heart doesn't beat. So then what happens is it'll go like that. And it'll beat, and there'll be a depolarization with no blood stream because the blood hasn't come in from the atrium yet. So there's no blood in the ventricles. So if you're feeling the pulse, it'll go bump, 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 bump. A lot of people have that happen every day in their lives. If I don't drink enough water and I drink too much caffeine, I get them all the time. But anyway, it's not a problem as long as it's like one rogue cell in a ventricle. Where the problem happens is if you start getting multiple rogue cells, all start getting irritated. Say, hey, we need more blood. I say, no, you're not doing your job. And they all start trying to take over. And then what happens if one of them fires during the repolarization, which is the P wave, it's just like that commode course we talked about. Someone hits you straight in the chest right as repolarization is happening. It'll then send the heart into chaos. Just all the cells will be depolarized at the same time, and the heart will just quiver and won't beat. That's sudden cardiac death known as ventricular fibrillation. So if you can get an AED on in the first 2 minutes, and you can shock them, what a shock does from an AED, people think it's like Igor Frankenstein, he's alive, shocks them back to life. Actually, what it is, it's a complete reboot. It's like shutting your cell phone off, starting it again, pulling the battery out, or hitting control, deleting it on the computer. What it does, it's a blast of energy to depolarize all the cells, give the SA node a chance to take over the leader and get a synchronized heartbeat. That's the objective of fibrillation. Does that make sense? Now, if it doesn't make sense, the way I look at this, everybody's seen old westerns, right? Usually some gonna have a fight in a bar, in a saloon, usually over a lady of the night. Well, those are all ventricular cells. And when they start hitting each other in the head with beer bottles and breaking tables and stuff like that, that's defib. So how do you stop every bar fight? Marshal comes in, what's he do? Fires a shot in the ceiling, everybody shuts up. Well, the marshal was an AED. Fires a shot in the ceiling, everybody shuts up. Lets the leader take over again. Heart starts beating. That's the whole concept of an AED. Any questions? All right, now we're gonna go over, let somebody way smarter than me explain it better. One of these days I'm gonna do a TikTok of the heart dominance, but I haven't had time for that. I think it'd be kind of cool. Now here's something I hope you'll really like.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potential descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cell to contract in unison, providing a strong contraction.
Any questions? All right.
This animation explains how a cardiac cycle is produced by electrical impulses in the heart. The cardiac cycle starts when an electrical impulse or action potential is generated by the sinoatrial node. The electrical impulse travels along specialized conducting fibers in the walls of the atria, stimulating the atria to contract and pump blood into the ventricles. In the normal heart, impulse travels very rapidly. As a result, all the muscle cells in the atria contract together, producing a coordinated pumping action. The impulse also travels across the right atrium to the atrioventricular node, where it is delayed slightly to allow the ventricles to relax and fill with blood before they contract. The impulse travels along the bundle of His, where the conducting pathways divide in two, forming the left and right bundle branches, which lie in the interventricular septum. From the bundle branches, the impulse spreads into the inner walls of the ventricles via specialized conducting fibers, called Purkinje fibers. Finally, the impulse travels up the outer walls of the ventricles towards the atria. The rapid and controlled spread of the electrical impulse through the ventricles stimulates the muscle cells in the ventricles to contract together and pump blood efficiently to the lungs and body. As you will see, during atrial fibrillation, the electrical activity of the atria becomes disorganized. As a result, the pumping function of the atria is lost, and the rhythm and efficiency of the entire heart are disturbed.
Any questions? Cartoons are so much better than me trying to draw out a word.
I had a question.
Yeah,
Do we define ventricular fibrillation, just sudden heart death and?
so ventricular fibrillation, I was just talking about, it's when one of the ventricular cells tries to take over as leader, but doesn't during the repolarization phase. When it does that, it sends the dominoes backwards. So it hits, and then all the cells just try to depolarize at the same time, so the entire heart just quivers.
Okay.
So you just get that wildly erratic line, and there is no pulse.
Okay.
And it will not be fixed until someone resets the entire heart, which has to be through a blast of energy.
Gotcha.
Or precardial thump, but you guys can't do that.
Already count on.
Yeah. Basically come out of courts.
The heart's conduction system controls the generation and propagation of electrical signals, or action potentials, that cause the heart's muscles to contract and the heart to pump blood. This electrical activity can be measured at electrodes placed at specific points on the skin, from which a composite recording is produced in the form of a graph. This recording is known as an electrocardiogram, or ECG, sometimes referred to as an EKG, a tracing of the overall electrical activity of the heart, resulting from the propagation of many action potentials. Let's look at what happens during a single beat of the heart and how these events are depicted on an ECG. In a normal heart, each beat begins in the right atrium with an action potential signal from the sinoatrial or SA node, the heart's natural pacemaker. The signal spreads across both atria, causing the muscle cells to depolarize and contract, inducing a phase known as atrial systole. On the ECG, this atrial depolarization is represented by the P wave. The period of conduction that follows atrial systole and precedes the contraction of the ventricles is depicted on the ECG by the PR segment, a flat line following the P wave. When the signal leaves the atria, it enters the ventricles via the atrioventricular or AV node, located in the interatrial septum. It enters the bundle of His and spreads through the bundle branches and the large diameter Purkinje fibers along the ventricle walls. As the signal spreads through the ventricles, the contractile fibers depolarize and contract very rapidly, inducing ventricular systole. The ECG's QRS complex represents this rapid ventricular depolarization. Atrial repolarization also occurs at this time, but any atrial activity is hidden on the ECG by the QRS complex. Finally, as the signal passes out of the ventricles, the ventricular walls start to relax and recover, a state described as ventricular diastole. The dome-shaped T wave on the ECG marks this ventricular repolarization. On the ECG, the ST segment depicts the period when the ventricles are depolarized. The QT interval represents the time it takes for both depolarization and repolarization of the ventricles to occur. The sequence of events just described and the associated ECG trace repeats with every heartbeat. Remember, an ECG is not a tracing of a single action potential, but an amalgamation of the many action potentials that constitute the electrical activity of the heart.
Any questions? All right, now we're gonna learn about those arteries.
Armando Hasurungan, biology and medicine videos. Please make sure to subscribe, join the forum and group. For the latest videos, please visit Facebook Armando Hasurungan. In this video, we're going to look at the coronary artery and the cardiac veins. So the coronary blood supply is the circulation of blood in the blood vessels of the heart. You have coronary arteries and the veins. Let us look at the coronary arteries first. Coronary arteries supply blood to the heart muscles. So we'll first look at the anterior view of the heart and look at the coronary arteries from there. So here we have the aorta in red, rich in oxygenated blood. The two main coronary arteries are the right coronary artery and the left coronary artery. Concentrating on the right coronary artery, it will divide into the right posterior descending artery that goes around the back, and we have also the acute marginal artery, that the small part that you can see in the front. And these arteries from the right coronary artery will supply the right atrium, the right ventricle, and the sinoatrial and atrioventricular nodes, which are the conduction systems of the heart. Unfortunately, I have not drawn these names here. Anyways, we also have the left coronary artery that will divide to the left anterior descending artery and the circumflex artery. These arteries will supply blood to the left atrium and the left ventricle. Now, if we look at the heart from the posterior view, so from the back, here we have the left side of the heart and here we have the right side of the heart. And just so we know where we are, this is the right atrium here, and this is the left atrium here. Now let's continue looking at the coronary arteries, which came from the anterior view. This is part of the right coronary artery, the posterior descending artery that wraps around to the back here and supplies the right ventricle and the right atrium with blood. On the left side here is the circumflex artery, which I mentioned, that wraps around and supplies the left atrium with freshly oxygenated blood. Wherever there are arteries, there will always be veins. The veins will leave the cardiac muscle cells and will bring the deoxygenated blood back to the right atrium through the coronary sinus. So the veins that will bring the deoxygenated blood back to the right atrium, it will bring it through the coronary sinus. So all the deoxygenated blood from heart muscles will go back through the coronary sinus back to the right atrium. You have the small cardiac vein from the right side of the heart joining with the coronary sinus. And then the middle vein from the right ventricle here joining onto the coronary sinus. We also have the posterior vein from the left ventricle joining onto the coronary sinus, bringing back deoxygenated blood to the right atrium. Here we have the great cardiac vein, which we can see comes from the front of the heart here. This is the great cardiac vein. And just to remember, this is the small cardiac vein here. Also, that is very important, there is an anterior vein that does not join onto the coronary sinus, but drains blood directly to the right atrium. So this vein is very important to remember because the anterior vein does not join to the coronary sinus, but drains deoxygenated blood directly to the right atrium. And so I hope you enjoyed this drawing on the cardiac arteries and veins. Thank you for watching.
Any questions? Any questions about the arteries and the veins? Blood flow through the body. All right, so when those coronary arteries become compromised, they get too much plaque in them, they can't get enough blood flow. Your cardiac cells have lack of oxygen, which is called ischemia. There'll be lots of test questions about the word ischemia. You have to know what it means. Ischemia means lack of oxygen to the cells. So, if it goes for too long or completely stops blood flow to those cells, they will die from lack of oxygen. If the heart tissue dies, that's called an acute myocardial infarction, abbreviated AMI. Acute meaning sudden onset. Myocardial meaning heart. Infarction means depth of tissue. AMI. The common term for that is heart attack. Now, the pain from ischemia is called angina. Just because they're having angina does not mean the tissue's dying, but it does mean if something isn't done quickly, the tissue likely will die. Does that make sense? So when someone's experiencing angina, it's a true emergency. Any questions so far? How does this happen? Well, the lead culprit is arteriosclerosis. That is black blood buildup of plaque inside the artery walls. The more plaque there is, the less blood flow, the more chance of having cardiac compromise. Especially when cardiac demand increases from work, walking upstairs, running, lifting a heavy object, etc. Any questions so far? So again, angina pectoris, the pain from ischemic cardiac cells. Now, there's a lot of different ways angina presents. Presents differently in different ways to different people, but the most common classic presentation is a pressure squeezing type pain that often radiates to the shoulders, the arms, the back, or the neck or jaw. That's the classical ones. There is no way to truly tell the difference between angina and a true heart attack. The only sign or symptom is if they rest or get some oxygen, it goes away. Or if they take a drug called nitroglycerin, it goes away, but it's not a true heart attack. So what's nitroglycerin? It's an explosive compound. What? Go ahead. It's a smooth muscle relaxer. So your arteries are muscles. So if smooth muscle relaxer relaxes your arteries, which dilates them, that allows more blood flow to go through it. Problem with nitroglycerin is it's not prejudiced. It doesn't go, oh, I'm just going to go dilate the coronary arteries. It dilates every artery in your body. So your blood pressure can rapidly drop. That's why you never give nitro to someone that's standing up, because there's a good chance they're going to syncopate from lack of blood flow to the brain. So we'll get into that. That's deadly. Now, if it's a true heart attack, resting, oxygen, and nitro is not going to work. So that's because usually there's a piece of plaque that's completely blocking the entire artery. So, but that's one of the ways you tell the difference between angina and a heart attack. Now here's something we hope you'll really like.
Angina is a symptom of a serious condition called coronary heart disease, also known as coronary artery disease. The heart's job is to pump oxygen-rich blood throughout your body. To do its job, the heart needs a steady supply of blood. The vessels that supply blood to your heart are called coronary arteries. These very important vessels are located on your heart. In a healthy heart, blood flows freely through the coronary arteries, providing the heart with the oxygen it needs to work properly. In coronary heart disease, the vessels become stiff and narrow, making it difficult for oxygen-rich blood to reach your heart. Reduced blood flow that occurs following exercise or emotional stress leads to chest pain or discomfort known as chronic stable angina, which is relieved by rest or nitroglycerin. If a clot develops in the coronary artery, blood flow is reduced more severely. This leads to chest pain known as unstable angina, which usually occurs at rest, and it requires immediate medical attention. In summary, when blood flow is reduced, your heart does not get as much oxygen as it needs, so it cannot pump blood like it should. This lack of oxygen is what causes the pain and discomfort of angina. If you have coronary heart disease, angina is your heart's way of telling you that it needs more oxygen. Talk with your cardiologist if you have questions about angina.
Any questions about angina? If you do, talk to your doctor. Just kidding. You can ask me. All right, so let's say a piece of plaque breaks off from there and it lodges and completely blocks an entire coronary artery. Everything distal to that, that tissue is going to die. It does not get reopened. And that's called acute myocardial infarction. And when that tissue is dead, it never comes back. The person's going to be a cardiac cripple the rest of their lives.
How long does that be roughly?
Yeah. 90 minutes to 3 hours. Generally, if you can get the artery opened in 90 minutes from the first onset of symptoms, you can have 100% recovery. That's tough to do though, because you got to get them into a cath lab under an interventional radiology and go with a wire, which we're going to show you about, and reopen the artery from inside. It's the fastest way to do it. That's pretty hard to do. Get them in there and get all that done in 90 minutes. Now here's something we hope you'll really like.
Let's talk change the tire game. More than
One of your what?
Die. Coronary arteries get replaced.
The artery dies?
Yeah, like when the coronary arteries, the tissue dies, they have to be replaced.
I've never heard of tissue in the artery die.
No,
I mean, like the clot blocks the artery?
Yeah.
No. Now, if it's severely compromised, they can't open it, but it's got like 5% blood through it, just a little trickles going through. They can't take veins out of your leg and they can bypass around it. The aorta is called a bypass surgery. But if it's completely blocked, bypass surgery won't be faster. This presentation is brought to you by Les Schwab.
70 years ago. Today, we still believe that you should get more from less, like exclusive tires.
If you have acute coronary syndrome, you have one or more conditions caused by a blockage of blood flow to your heart muscle. This is a medical emergency because you may be having a heart attack, a condition in which your heart muscle begins to die. Your heart is a muscular organ that pumps blood containing the oxygen and nutrients your body needs. The main pumping chamber of your heart is the left ventricle. When your left ventricle contracts, it sends oxygen-rich blood to your body through a large artery called the aorta. Connected to your aorta are small arteries called coronary arteries. Blood flows from your aorta through the coronary arteries to supply your heart muscle with oxygen and nutrients. If you have acute coronary syndrome, blood flow through your coronary arteries is severely reduced or completely blocked. One possible cause of reduced blood flow is atherosclerosis. In this condition, a buildup of a fatty substance called plaque can narrow your coronary arteries. If this plaque ruptures, a blood clot can form and block the artery. A blood clot is the most common cause of coronary artery blockage. Other less common causes of reduced blood flow include coronary artery spasm or dissection. In a coronary artery spasm, triggers such as drugs, smoking, cold weather, and extreme stress or emotions can cause a temporary and sudden tightening of a coronary artery. During a coronary artery dissection, the inside wall of one of your coronary arteries separates, which can block blood flow. Regardless of the cause, a blockage in either coronary artery prevents the oxygen and nutrients in your blood from reaching the part of your heart supplied by the artery. As a result, heart muscle in that area starts to die. Death of part of your heart muscle is called a heart attack. It's also known as a myocardial infarction, or MI. A blocked coronary artery may also cause you to feel sudden pain, discomfort, tightening, or a burning sensation in your chest called angina. This pain may extend to your upper abdomen, shoulders, arms, neck, and lower jaw. If you have angina when you're at rest, or frequent angina that prevents even moderate physical activity, you have unstable angina, which is the main symptom of acute coronary syndrome. Other symptoms of acute coronary syndrome include shortness of breath, dizziness, nausea, and sweating. If you've had a heart attack or have other types of acute coronary syndrome, your doctor may prescribe oxygen therapy to get more oxygen into your blood. You may take aspirin or other prescription blood thinner drugs to prevent blood clots. Thrombolytics, also known as clotbuster drugs, may be used to break up any existing blood clots. Drugs such as nitroglycerin and morphine will relax your coronary arteries and relieve the pain of angina. You may also receive drugs called beta blockers that slow down your heart and reduce its need for oxygen. Your doctor may also recommend immediate surgical procedures such as coronary angioplasty, in which a balloon-tipped catheter inflates inside your blocked coronary artery to open it. After inflating, the balloon catheter may leave behind a mesh-like device called a stent to hold your artery open. Or you may have a coronary artery bypass graft, or CABG. CABG is a surgical procedure in which the blocked areas of the coronary arteries are bypassed with veins or artificial graft material. Seek treatment immediately if you have the symptoms of acute coronary syndrome.
I can't believe the sleep apnea pillow exists.
Cardiac compromise is a blanket term that refers to many kinds of problems with the heart. Just as there are many problems, there are a wide variety of signs and symptoms associated with these heart problems. As an EMT, it is much safer to treat all patients as though they are having a heart problem, rather than diagnose the specific disorder. With that in mind, let's take a closer look at 5 of the most common heart conditions. Coronary artery disease. Coronary artery disease occurs when the coronary arteries are narrowed or blocked, reducing the amount of oxygen delivered to the heart. 2 conditions, atherosclerosis and arteriosclerosis, commonly cause the narrowing or blockage of arteries. Atherosclerosis is a buildup of fatty deposits on the inner walls of arteries. This buildup causes a narrowing of the inner vessel diameter, restricting blood flow. Fats and other particles combine to form plaque. Arteriosclerosis is a stiffening or hardening of the artery wall, resulting from calcium deposits. Often called hardening of the arteries, this condition causes the loss of elasticity, changing blood flow and increasing blood pressure. These conditions can facilitate rough surfaces, making them vulnerable to blockages. A large thrombus can cause an occlusion, or it may break loose to become an embolism and form blockages elsewhere. When blockage occurs, tissues may die, and in certain cases, this can be fatal. Acute myocardial infarction. Acute myocardial infarction occurs when a portion of the myocardium, heart muscle, dies as a result of oxygen starvation. The dead area can no longer pump. This can lead to cardiac arrest, shock, pulmonary edema, or congestive heart failure. In some cases, heart attack patients suffer cardiac rupture as the dead tissue area of the heart muscle bursts open. Medications called thrombolytics dissolve clots that block coronary arteries. Other patients receive an angioplasty, a balloon device to open the arteries. Aneurysms. Weak spots that dilate are known as aneurysms. When a weakened artery bursts, rapid internal bleeding occurs and tissues beyond the rupture can be damaged. A rupture of an artery within the brain can result in a severe stroke. If a major artery ruptures, death from shock can occur. Arrhythmia. A malfunction of the heart's electrical system will generally result in an arrhythmia. Electrical disturbances within the heart result in arrhythmias, including bradycardia, abnormally slow, less than 60 beats per minute, tachycardia, greater than 100 beats per minute, or rhythms that are present when there is no pulse, including ventricular fibrillation, ventricular tachycardia, pulseless electrical activity, and asystole. Congestive heart failure, CHF. Congestive heart failure, CHF, is a condition of excessive fluid buildup in the lungs and other organs because of inadequate pumping of the heart or a failure of the lungs to function properly. Congestive heart failure can be caused by diseased heart valves, hypertension, or some form of obstructive pulmonary disease. The symptoms of CHF may include tachycardia, shortness of breath, elevated blood pressure, cyanosis, profuse sweating, cool and clammy skin, pulmonary edema, pedal edema, or the coughing up of frothy white or pink sputum. Late signs include engorged pulsating neck veins or enlarged liver and spleen with abdominal distension.
Any questions? All right, so there's your signs and symptoms of angina. So if you can get them in 90 minutes and get that artery open, they can have full recovery. If you can't, it's not going to go well. We do not put them on high flow 2. We put them on 2 liters of oxygen and titrate to 94%. Don't delay transport. Ask for an advanced life support intercept. Now, why is advanced life support intercept important? Well, let's see if I can hold on to it further. This is why. So, remember the PQRST? So you can actually even help the paramedics set up to this too as an EMT. The paramedics can look at the heart with a 3D grid. So they can look at 6 horizontal views and 6 vertical views. And what they're looking for is if the tissue is ischemic, what it's going to do is P wave will be normal, QRS will be normal, but the T wave is going to have to repolarize around it, so you're going to have an elevated ST segment. That's what it's going to look like. So a normal one looks like that. They're going to look for that. So they're going to look at 6 horizontal views, 6 vertical views. And if they see that horizontal and vertical views of consecutive leads, they'll know which artery is compromised, where the ischemia is. Then that way they can contact what they call a cath lab, cardiac team, and have them ready to go. So as soon as you get to the hospital, just like a trauma alert, they take them straight in, go in through the groin, run a catheter up, put a wire puncture through the clot inside the coronary artery, dilate it with the stent, and restore blood flow. Pretty cool, huh? Any questions?
For the grids, are you talking about on the G?
So you got your 4 limb leads, and then they go V1, 2, 3, 4, 5, 6. And then 2 of those leads, it's 10 leads, but 2 of them do double duty. And that's why they call it a 12th lead. Any questions? The sooner that's done, the better the chance getting that patient into what they call a cath lab and getting the artery open again. So the signs and symptoms of acute myocardial infarction are the same as angina pectoris. The only difference is It doesn't go away with rest or oxygen or nitroglycerin. Any questions? No questions. Treatment, not high flow 2 liters per minute, titrate 94%. Position of comfort, immediate transport, advanced life support, intercept if possible, but do not delay. So STEMI, that's ST elevated myocardial infarction. That's that ST segment elevated for a myocardial infarction. STEMI, STEMI, STEMI. You'll hear that word a lot in EMS.
You said.
Yeah.
High flow O2?
Do not use high flow 2.
Okay.
Not anymore. We've learned. So, PCI, which is percutaneous coronary intervention. There'll probably be a test question on that too. If you can get PCI within 90 minutes of the onset of symptoms, they have an excellent chance of survival with almost no cardiac damage. The longer outside that window of 90 minutes, just like decompensated and irreversible shock, the more that tissue is going to be dead. Any questions? PCI stands for percutaneous coronary intervention. There will probably be a question at the end of the night that tells you that you didn't do your chapters. Yes.
Is myocarditis the same thing as a myocardial infarction?
No. Myocarditis is an infection or an inflammation of the cardiac tissue, usually from bacteria or virus. So that is different.
Okay.
And it can present similar with difference. So it's one of the ways you can tell it's myocarditis is you'll actually have ST elevation in every one of the 12 leads. That's how they know it's an infection of the tissue.
Oh.
Any questions? All right, so this is what a PCI is. Percutaneous coronary intervention.
This one or this one? Sam, are you cheating on?
Coronary angioplasty, also called percutaneous transluminal coronary angioplasty or balloon angioplasty, is designed to restore the flow of blood through coronary arteries narrowed or clogged by atherosclerotic plaques or blood clots. When you arrive at the hospital, an intravenous line will be started. You will be placed on a heart monitor and you will be given an oral or intravenous sedative to help you relax. Most coronary angioplasty procedures last between 30 minutes and 3 hours. The doctor numbs the skin in your groin area and inserts a needle into your femoral artery. Once the needle is placed, a guide wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath, permitting access to your femoral artery. At this point, you will be given a blood thinner to reduce the risk of blood clots. Next, a soft, flexible catheter is slipped over the wire and threaded up to the heart. The procedure is monitored using a continuous X-ray imaging device called a fluoroscope. You may feel pressure as the wire and sheath are inserted through the groin and pushed through the artery, but you will not feel their movement inside your arteries. At this point, your doctor will remove the guide wire, position the tip of the catheter just inside the coronary artery to be treated, and inject a special dye. The dye allows the fluoroscope to take X-ray images, called angiograms, of the artery's interior. Any blockages will be clearly identified as the arteries fill with the dye. You may feel flushed or slightly nauseated when the dye is injected. Once the blockage is identified, your doctor will insert a flexible guide wire into the artery and advance a balloon-tipped catheter over this wire and into position at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, reestablishing blood flow through the artery. You may feel some chest pain while this is happening. The same procedure is repeated for each blockage being treated.
Afterwards, your doctor will withdraw the deflated balloon and catheter from your arteries. Some patients will receive a coronary stent, which is a small tube made of wire mesh designed to prop open the artery once it has been treated. A collapsed stent is placed over the deflated balloon as it's moved into position. When the balloon is inflated, the stent expands and locks into place. After the balloon and catheter are withdrawn, the stent remains behind to hold the artery open permanently. After your procedure, a pressure bandage will be applied over the femoral artery to prevent bleeding. You will need to lie on your back for several hours, during which time you will be checked periodically for any signs of bleeding or chest pain. You may either be discharged home on the same day or after an overnight stay in the hospital.
Any questions? All right. So we're gonna jump ahead on this one. So this is an actual PCI being done in a cath lab. You can actually see where the artery reopens. Or we're gonna jump ahead to 8:13 when that happens.
This is a 57-year-old gentleman who presented with from the back of the heart and plaque. And so to make the artery ready for the stent, we need to withdraw. Here's there. The second picture after one pass was just a clot. And then we made two more passes with the export vessel, export catheter, and one inflation with a balloon in the beginning of the artery. And that's how we ended up with this.
Look at that. See the difference?
And now we're going to put stents in this artery. So we'll put the 3/0 distal just at the crux.
Any questions? So they can't pass the wire through the coronary artery in a percutaneous coronary intervention, then they're gonna have to resort to bypass. This is how a bypass works, also as a CABG, coronary artery.
A coronary artery bypass graft, or CABG, is performed to improve circulation to the heart muscle in people with severe coronary artery disease. In this procedure, a healthy artery or vein from another part of the body is connected or grafted to the blocked coronary artery. The grafted artery or vein bypasses the blocked portion of the coronary artery, carrying oxygen-rich blood to the heart muscle. One or more coronary arteries may be bypassed during a single operation. Before the surgery, an intravenous line will be started, and you may be given a medication to help you relax. CABG procedures are done under general anesthesia, which will put you to sleep for the duration of the operation. A breathing tube will be inserted through your mouth and into your throat to help you breathe. A catheter will be placed in your bladder to drain your urine. Coronary artery bypass surgery generally takes 3 to 6 hours. During a conventional bypass surgery, your surgeon begins by making an incision in the skin over your breastbone or sternum. He or she will then cut the sternum and move your rib cage in order to get to your heart. Throughout the procedure, your circulatory system will be connected to a cardiopulmonary bypass pump or heart-lung machine. This machine temporarily performs the functions of your heart and lungs during the surgery, allowing your heart to be stopped while the surgeon sews the grafts into place. One of two blood vessels is typically used for the grafts: the internal thoracic artery in the chest or the saphenous vein in the leg. For the internal thoracic artery graft, your surgeon will leave the upper end attached to the subclavian artery and divert the lower end from your chest wall to your coronary artery, just beyond the blockage. Your surgeon will then sew the graft into place. For the saphenous vein graft, your surgeon will suture one end to the aorta and the other end to the narrowed artery just beyond the blockage. With the graft securely in place, your surgeon will use electrical signals to restore the heartbeat and attach a temporary pacemaker to the heart. Once your heart is again beating normally, the heart-lung machine will be disconnected. Your surgeon will wire the breastbone back together and suture the skin incision closed. A temporary drainage tube will be placed through the skin beneath the incision. 2 other types of CABG procedures have recently been developed: off-pump and minimally invasive bypass surgery. Off-pump CABG is also called beating heart bypass grafting because the heart isn't stopped and heart-lung machine isn't used. Instead, a mechanical device is used to steady the part of the heart where grafting is being done. Surgeons perform minimally invasive bypass procedures using specially designed instruments inserted through small incisions or ports in the chest. These procedures sometimes require a heart-lung machine. After surgery, you will be taken to the intensive care unit. The activity of your heart will be carefully monitored. If necessary, the pacing wires will be used to temporarily control your heart rate. The chest tube will remain in place to drain excess blood and air from the chest cavity. Once you can breathe on your own, your breathing tube will be removed and replaced with an oxygen mask. The bladder catheter will remain in place. As you recover over the next 3 to 4 days, all of these devices will be gradually removed.
So, you're not able to open the artery in time, the heart muscle dies. That's what causes congestive heart failure and cardiogenic shock, which are opposite ends of the spectrum. So cardiogenic shock, your heart's too weak to pump. And early recognition is key to your assessment. Again, if you can get them to advanced life support, paramedics can do external pacing and mimic the SA node to make the heartbeat stronger and faster. So how are you going to know they're in cardiogenic shock? They're going to have cold, pale, wet skin, and low blood pressure. Usually bradycardia, heart rate under 60. Shortness of breath and a complaint of severe weakness. Any questions? This one we do use high flow too. Try to keep them sitting up. Be prepared to ventilate. Be prepared to do CPR. Transport as soon as possible. Advanced life support as soon as possible. Any questions? So congestive heart failure is the opposite of cardiogenic shock. It's when your heart's failing, but your body's compensating. We went over that last night. Any questions? Starts with the left ventricle, proceeds to the right ventricle. You'll end up with hypertension, tachycardia, rails, jugular vein distension, pitting edema. Any questions? Here's the video again. For those
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Any questions on CHF? Signs and symptoms again. There will be test questions. Any questions? Treatment, high flow 2, CPAP if you got it. It's amazing. Don't delay transport, advanced life support. Nitroglycerin helps a lot too. Any questions? All right, that brings us to hypertensive emergencies. This is when people have high blood pressure for too long. The pressure gets so high for so long, it weakens the walls of the aorta, and the aorta starts to rupture. If your aorta ruptures, you're a goner. There's no coming back. That's why you need to make sure your high blood pressure is treated.
This season, you've got places to go, people to see, and things to do. You may have already gotten vaccinated for flu and COVID-19, but other respiratory illnesses are still out there. If you're 50 or older, even if you're healthy, it may be important to help protect against pneumococcal pneumonia. And if you have certain health conditions, it may be important to help protect against RSV too. Talk to your doctor or
Blood pressure is the force the circulating blood exerts on the walls of blood vessels. It is different in different types of vessels, but the term blood pressure, when not specified otherwise, refers to arterial pressure in the systemic circulation. When the heart contracts and pumps blood into the aorta during systole, the aortic pressure rises, and so does the systemic arterial pressure. The maximum pressure following an ejection is called the systolic pressure. In between heartbeats, when the ventricles refill, blood pressure falls to its lowest value called the diastolic pressure. These are the two numbers on a blood pressure reading. Blood pressure normally shows a daily pattern and is usually lower at night. During daytime, it fluctuates with physical activities and emotional states. Hypertension refers to a persistent high blood pressure. In the US, high blood pressure used to be defined as greater than 140/90, but recent guidelines have changed these values to 130/80 to better prevent and treat the condition. Normal blood pressure is below 120/80. In practice, blood pressure is considered too low only if it produces symptoms. Hypertension does not cause symptoms on its own, but it slowly damages blood vessels, and in the long term is a major risk factor for a variety of cardiovascular diseases such as stroke, aneurysm, and heart attack, as well as end organ damage such as renal failure or vision loss. For this reason, hypertension is known as the silent killer. Hypertension can be classified as primary or secondary, with the former being responsible for over 90% of cases. Primary hypertension has no apparent cause and may develop as a result of old age, obesity, high salt diet, lack of exercise, smoking, and drinking. Most commonly, the blood vessels are hardened with age or unhealthy diets, making it harder for blood to flow. Secondary hypertension, on the other hand, is caused by an underlying condition. Many conditions and factors can cause hypertension. Most notable are kidney problems and endocrine disturbances. Regardless of the cause, the increase in blood pressure is produced by either an increase in vascular resistance, narrower or stiffer blood vessels, or an increase in cardiac output, larger volume of blood pumped out by the heart. These two factors are the targets of antihypertensive drugs. Treatments must start with lifestyle changes such as healthy, low-sodium diets, physical exercise, and stress management. On top of that, antihypertensive agents may be used to control hypertension. These include vasodilators. These drugs dilate blood vessels, thereby decreasing vascular resistance and reducing blood pressure. Diuretics. Diuretics promote sodium and water removal by the kidneys and thereby decrease blood volume. Drugs that decrease cardiac output by decreasing heart rate or contractility may also be used to treat hypertension.
Any questions? What happens if you don't treat it? Everyone's seen like what an aneurysm in the hose looks like. Well, it's no different in your aorta. Starts to bubble. And then, if it doesn't get treated, it will rupture. So you can have a thoracic aortic aneurysm, or you can have an abdominal aortic aneurysm, depending on where it's at. Often they're not going to know they have it until the very end, and they start feeling the pain, then it's usually too late.
The aorta is the largest artery in your body. Your heart pumps fresh, oxygen-rich blood through your aorta to deliver oxygen and nutrients to all your organs and tissues. Your aorta is divided into two main sections, the thoracic aorta and the abdominal aorta. The thoracic aorta has four parts: the aortic root, ascending aorta, aortic arch, and descending aorta. The wall of your aorta is composed of three layers that give it strength: the intima, or inner layer, the media, or middle layer, and the adventitia, or outer layer. The elastic muscular media prevents your blood pressure from rupturing the wall. Over time, degenerative disease may cause the media layer to break down, weakening the wall of your aorta. Blood pumping against the weakened area may cause it to bulge outward like a balloon. When this condition occurs in your chest, it is called a thoracic aortic aneurysm. These aneurysms may occur in one of several places, including the aortic root, the ascending aorta, or the descending aorta. Most thoracic aneurysms have no symptoms. However, when they reach larger sizes, various symptoms may appear, depending on the severity and location of the aneurysm. Symptoms of stable thoracic aneurysms may include shortness of breath, chest, back, or abdominal pain, difficulty swallowing, and hoarseness. If the aneurysm ruptures or dissects, more dramatic symptoms will appear, including a ripping sensation in the chest, severe pain in the back between the shoulder blades, dizziness, and difficulty walking and speaking. If you have these symptoms, you should seek immediate medical attention, as this condition is life-threatening. Blood pumping against weakened aortic walls can lead to another life-threatening condition called aortic dissection, which may or may not occur within an aneurysm. Most commonly, aortic dissection begins with damage to the intima layer. Blood moves through the break in the intima, separating it from the media, causing bleeding inside the wall of your aorta. As a result, a flap called a septum forms between the true aortic channel and the false channel. From here, the blood may break through the outer layer of the aortic wall, causing an immediate life-threatening condition. Or it may re-enter the aorta through another tear in the intima. Over time, a blood clot may form in the false channel. An aortic dissection may be classified according to its location and duration of symptoms. In the Stanford system, if you have an aortic dissection in your ascending aorta, it is called a type A dissection. All other dissections are called type B. The most common symptom of thoracic aortic dissection is sharp or stabbing chest pain, usually sudden and severe. If you have a type A dissection, you're most likely to feel pain in your chest. If you have a type B dissection, you're more likely to feel pain in your back than your chest. If you have these symptoms, you should seek immediate medical attention, as this condition can be life-threatening.
Drinking warm water before bed improves eyesight almost overnight.
Yeah, sure. So you're gonna get a lot of the same signs and symptoms as an AMI, acute myocardial infarction, but the more telltale sign is they'll tell you it feels like someone's taking a sword and putting it straight through their chest and out their back. And that's in, what's that?
Right there in the center.
Or they're in the center or the left side and going straight through their back. That's a telltale aortic aneurysm sign. Especially if accompanied with hypertension. Sending with abdominal pain. They say it feels like someone's putting a sword through their stomach, going out their back. And they have a history of being a smoker. 9 out of 10 abdominal aortic aneurysms are smokers. That with hypertension, unless it's late stage, then they're not going to have hypertension. The other thing to look at is demarcation line on the back. Everything's kind of a purplish or cyanotic color below it. Loss of pedal pulses because there's no blood flow getting down there because it's dissecting. Any questions? So what do? So in the olden days, what they do is they take a graft from a cadaver and they plant the aorta and then cut it and then try to graft in a new graft where the aneurysm is. Nowadays, they try to fit you with an internal sleeve.
Talent thoracic duplex.
And they'll
markers on the talent thoracic.
they'll go through your groin like
covered
for
portion of the
PCI.
indicates the position of the perform angiography.
They
to
dilate
verify the
internal
position of the
sleeve,
stent graft in relation to the desired
way
location.
less invasive than
If the
splitting your
stent graft
chest
was
open and
deployed
snapping out
higher
apart
than
and
the
trying to put a
targeted landing
cadaver
zone,
graft in.
the stent graft can be repositioned distally to its desired location by
Any
retracting it.
questions? It's kind of cool. All right. Well, let's see what you guys have learned. You've been dispatched to a possible heart attack in a residential area of a small town. It's mid-afternoon. What do we do first? Everybody's got their BSI and the scene safe, nature of illness, chest pain. You have one patient, full rescue squad. It doesn't appear you need spinal mobilization. What comes next? Do we just order O2 automatically? No. Yeah, it should be a shinky. All right. Initial impressions, mid-50s male, left lateral come on the couch. He's alerted, he's got chest pain, strong radial pulse, airway's clear. He's breathing adequately, so we put him on 2 liters of O2, titrate to 94%. He's pale, cool, and wet for chest pain. Is this a priority patient? What's next? History. Signs and symptoms are chest pain. Awoke with pain, onsets 07:30. Provoked on awakening, crushing quality, radiating to his left arm and jaw. 9/10 severity has been constant for 8 hours. Ugh. Allergies, he's allergic to Advil. Medication takes lisinopril, which is for high blood pressure, and metformin, which is type 2 diabetes medication. Past history, high blood pressure and non-insulin dependent diabetes mellitus, which is type 2 diabetes. Events leading up to it, he woke up this morning. What's next? What's the next part of the assessment? Secondary exam. Blood pressure is a little high, tachycardic, Glasgow's 15. Physical exam's negative. But it's been going for how many hours? Started at 7:30 this morning. He's been resting. This hasn't gone away for 8 hours. Is this angina pectoris or an AMI? Yeah. What do we do? Oxygen, get it moving. I have no idea what this is.
But lifeguards respond to a cry.
So most of the videos I show you is what not to do. This is exactly how to handle someone not breathing. This guy's not a full arrest, but he's a near drowning. And you could not have handled this call better.
Lifeguards bring the unconscious man to shore with the help of good Samaritans.
The first thing they do is bring him up all the way out of the water and try to keep him dry.
And one lifeguard stays with the victim. Lifeguard Gillis rushes for his medical kit. Each passing second could be the difference between life and death. Additional lifeguards come to the aid of the victim. They quickly work to assess the man's condition. The man is not breathing. Lifeguard Gillis tries to clear his airway.
This report is an unresponsive patient who is not breathing or not breathing adequately.
An ambulance is on the way. But if lifeguards can't expel the water from his lungs, it may be too late.
We need to get oxygen in him as soon as possible so we can bring him back. Hey, can you hear us? Can you hear us?
Coming up, back in Waikiki, lifeguards work furiously to revive the elderly drowning victim, who is still not breathing on his own. They use a BPM device to get desperately needed oxygen into his lungs.
The BPM is bag valve mask, and we use that on unconscious victims. So we're usually do it up there way breathing.
The man is still not responding, and his vital signs are fading fast.
We're trying to breathe for the patient, and it's basically one breath every 3 to 5 seconds. The patient has a pulse, so we're not doing compressions, but we're just basically breathing for them.
The victim has been unresponsive for more than 7 minutes. His chances of survival fade with every passing second.
Hey, buddy, can you hear us? Can you squeeze my hand? Do you know this person, man?
Acting Lieutenant James Sloan races to the scene and finds the dire situation unfolding. Honolulu's fire department corresponds with the lifeguards. The victim is still unresponsive when suddenly the man is now breathing, but his respiration is weak and shallow. The situation remains grim.
Let's go back down and backward. Back down and backward. Back down and backward.
The victim is placed onto a backboard for immediate transport to the waiting ambulance. As lifeguards try to communicate with the victim, an hysterical relative threatens to derail the rescue effort.
He's gonna be okay, man. Come. No, relax. He's okay. Look, he's okay. Okay? He's breathing. Wait, come down.
The woman may hold vital information that could save the victim's life, but her broken English has lifeguards struggling to understand her.
Has he any medical conditions that we should know about? Heart attack? Yeah.
The man's extreme heart trouble could cause him to go into cardiac arrest. Time is running out. Lifeguards must quickly transport the man off the beach to a waiting ambulance for advanced life-saving techniques.
One, he knows what his name is, but doesn't know where he is and what happened. All right, his condition, as far as health wise, he's probably not the best, but he's looking pretty good at this time. Had this patient been alone and in rougher water, my guess is that he would not have survived. Enough patient plenty enough had a pulse and was breathing, so that's always good news for ocean safety care. What do you need?
do better than that. Pretty impressive, actually. I always tell people the most terrifying thing is not horror movies, it's watching live EMS. That was really good. Any questions? All right, aspirin. Aspirin's a miracle drug. And it's critically important in angina and heart attacks. So it does a lot of things. It's sold mostly as an analgesic, which is a pain reliever, but it also is an antiplatelet. It breaks down clots when they're around. It won't stop a clot that's already blocking a coronary artery, but any more clots that are breaking free and heading to block more coronary arteries and increasing the size of the heart attack, it can stop them en route. So if you can get aspirin on board as soon as possible for someone having chest pain and cardiac symptoms, you should do it. It should be the first thing. Generally, when you'll have a standing order for it, most states, California you do, it'll be 481 milligram tablets they have to chew up, swallow. The sooner that gets on board, the better their chances are. Any questions on aspirin and what it does and why you use it? Yes.
So if the pain reliever that stops platelets from making.
Yeah, we don't give it for pain relief. We're giving it to stop more clots that are on their way.
Yeah.
It dissolves them en route.
Okay, but doesn't stop an active blockage.
Yeah, once if there's a clot that's already blocking an artery, it won't solve that problem. But generally what happens in heart attacks, it's not just one lone rogue clot. Usually there's more coming. They're breaking free from pieces of plaque. And then other little arteries start getting blocked, and the heart attack grows in size. So what the aspirin does is it dissolves those clots en route so they don't block more arteries. So critically important. All right, nitroglycerin. So nitroglycerin is a smooth muscle relaxant. So it dilates the arteries. Now, if the artery's blocked, that's not going to matter. But if it's angina, it's going to make a huge difference. It's going to get oxygen to the cells. So, contraindications. It can drop their blood pressure rapidly. So you have to make sure they're sitting down and they can't fall over because there's a chance they'll pass out. You don't give it to anyone with a blood pressure of less than 100. Now, as Roger brought up, Viagra. It's not just Viagra, it's any sexually enhancing drug. So Viagra was invented not for sexual enhancement, but for long-term cardiac use. It's a vasodilator. And what they were thinking was instead of people having to take a nitro, because nitroglycerin only lasts 5 minutes. It's all advised you, it's 5 minutes of time. Then you got to take another one. So the idea of Viagra when they were trying to develop it was to give a long-term effect that would last for hours. So people could have a better quality of life. But what they found out is it didn't really work that well on clogged up coronary arteries. But they found out that it worked amazingly well on clogged up arteries in the penis and caused erectile. Now, the problem is it's a long-lasting vasodilator. So if you give it in conjunction with nitroglycerin, it's called potentiation, which is 1 + 1 = 5. It's like putting two bad teenagers together. But one bad teenager might steal a car, break a window. You put two of them together, they're going to burn down a department store. Probably not a good analogy. There's a lot of teenagers in here. Anyway, so you put nitroglycerin and Viagra together, it's going to cause a life-threatening blood pressure drop. So before you give nitro, you always have to ask if there aren't any sexually enhancing drugs. And they will lie to you, but then that's on them when they die.
And then it's below 100, right?
Yes, systolic below 100, do not give nitroglycerin. Take vitals before and after, just like any other medication. Any questions? And especially if it's black market, they'll lie about it also. Like right now, when Rite Aid and Mount Shasta closed, 2 cases of Viagra disappeared. Mount Shasta PD has no leads. All they know is it was hardened criminals.
Jesus.
All right, contraindications. They have a head injury systolic below 100. There is no maximum dose, and they've been taking sexually enhancing drugs. Any questions? So they should feel a fizzling sensation, give a tablet under their tongue or a spray under their tongue. It's given sublingually. They don't get a headache and feel the sizzling. That means the nitro is probably no good. It's very light sensitive and air sensitive. Once the bottle's broken, open, it probably doesn't last more than about 30 days. If it gets exposed to light, it lasts even less. Again, take the blood pressure before and after. Don't give it to anyone sitting on a bar stool, standing on the edge of a cliff. Use your 5 R's. Any questions? Put it under the tongue. Wait 5 minutes, document if they felt better. Any questions about nitro and aspirin?
What do you mean when you say 5 R's?
5 R's?
5 Reds?
You should. 5 R's, yeah. Right drug, right patient, right date, right dose, right route. All right, heart surgeons and pacemakers. We're running out of time. We're gonna finish this after exam 3 Thursday. So some people have implanted, they've had like right coronary artery dysfunction, it's killed the SA node. They'll have an implanted pacemaker. Some people have implanted pacemakers and defibrillators. Well, actually defibrillate them. So there'll be a box underneath subcutaneously underneath their chest. And then it's got a wire that goes around and stimulates the heart, just depolarizes the right atrium, stimulates the SA node. Your ventricles don't know the difference. Any questions on the AD? If it detects ventricular fibrillation or ventricular tachycardia, it will shock it. Question.
Oh, are the defibrillators like an actual like synthetic, like piece of technology in their body? How does your body not like react negatively to the foreign body inside of it?
It's just on the subcutaneous tissue.
Oh, okay.
It's not an organ transplant. So, and they put it in a sterile field, and sterile, so there should be no bugs on it. So there should be nothing for the body to fight. Whereas then when you put tissue in, like an organ transplant, that's living tissue that your immune system goes, what the hell is that? Tries to kill it. So that's why they have to be on anti-immune drugs the rest of their life.
Gotcha.
Any questions about the electrophysiology? You guys are all experts now. The domino effect of depolarization. Any questions about automaticity? So that's a regular rhythm. They call that a sinus rhythm when things are going normally, because it's the SA node, the sinus atrial node. So they named the rhythm after it, the sinus rhythm, because it's the leader. Any questions about what a sinus rhythm looks like? The maybe test question. Remember what PVCs are? That's when a rogue cell thinks it's not getting enough oxygen, tries to take over the leader, and it depolarizes before there's blood in the ventricle. So the whole heart doesn't beat. And you see it looks like that.
It's those like smaller jumps.
Huh?
Is it the smaller jumps or the like
The big ones.
Okay.
The regular ones, that's your regular sinus rhythm. Then bam! Some ventricle shoots his mouth off, but he's not supposed to. It's like that kid in science class who always got something to say. So you get multifocal PVCs, that's when you're getting it from multiple different ventricular cells. That's a problem when you have multifocal PVCs, then it increases the chance for ventricular fibrillation. Usually if it's just one jerk shooting his mouth off, it's not a problem. When you're getting it from multiple different ones, that's a problem, because eventually one of them's gonna happen during that T wave repolarization. And the whole heart just quivers and no blood flow.
And this is usually solved with AED shot.
Immediate CPR to keep blood flowing, because you're not gonna be able to pump blood in their arms, heart's just quivering. So immediate CPR and a shot as soon as possible.
Gotcha.
Remember, defibrillation, just rebooting the heart. Just like rebooting a cell phone or a computer. Any questions?
Can you show us the difference between a PVC and a PAC?
Maybe. PAC is just a pre-atrial contraction. Those will actually, because there's blood already there. So that's just early without a P wave. It's one of the atrial cells just beats first. There might be a slide in here on that. If not, I'll find you one after we go to break here in a minute. So that's what defibrillation looks like if you have a monitor on. Shocks. Here fires the bullet through the roof. Takes over normal organized rhythm again. Don't worry about that. We don't put defibrillators on people in case they die. We only put it on people that are in full arrest. Gotta have a CQI system. If you're working for an agency, county's gonna make you have a CQI system. All right, we'll watch one more video, then we'll go to break. This is a guy, this is in Australia. It's upside down, so you have to put the pads on backwards. They're on the other side of the earth. So it depolarizes the right way. That's just kidding. This is an older video though, so you'll see their CPR slow. It's before we got learned the things that we know nowadays. But it's a great save. I was lucky they were doing a photo shoot for the lifeguards, and everybody was there. It's the only reason why this guy lived. So we'll watch this and we'll go to break. Then I'll pull up a picture of a PAC for you.
1 p.m. midweek on Bondi Beach. A small crowd, gentle surf, perfect conditions.
Sensation.
It's not the time when you'd expect things to go wrong. 5 off-duty lifeguards happen to be taking part in a photo shoot following media interest in Bondi Rescue. Amongst them is Hoppo, the boss, and Corey, one of the most experienced lifeguards on the beach. Halfway through the shoot, a dramatic event unfolds right beside him. A man's found floating, lifeless in the surf.
Ready?
His name is Takahiro Ono, an English language student from Tokyo. No one knows what's happened to him or how long he's been in the water.
No. Someone going to get on the radio. There's a radio on my bottom corporate this here. Check pulse.
Hoppo can't detect a pulse.
Bang,
He's not breathing.
bang, come on. Bang.
Tucker is clinically dead.
You grab the mask?
The boys must get his heart beating again and air into his lungs.
It's a male, about 20 years old. They're going to bag now, get back to him.
Daniel arrives with the defibrillator as Corey starts CPR.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
Tucker still has no pulse.
Stay quick, stay quick. Stay clear. I'll take that thing. Stay on the ready?
The machine reads Tucker's vital signs.
Check pulse. Check pulse. I can't get one, so I'll take the oven.
The defib doesn't work on Tucker first time. The machine needs time to recharge. Corey continues CPR.
12. Yeah, copy that, Chapper. 30, 40, 50.
It's 4 minutes since lifeguards got to Tucker.
1, 2, 3, 4, 5, 6, 7,
The machine needs time to establish whether he has any heart rhythm.
It is clear. And that patient analyzing rhythm.
Tucker's had 2 shocks. He's in spasm. Patients rarely survive if they need more than 3 shocks. Tucker's been clinically dead for at least 4.5 minutes. He has 1 chance left.
And that patient analyzing rhythm.
The 3rd shock has finally had an effect.
Analyzing rhythm.
I shot again. Still staying good.
Analyzing rhythm.
So I
Check pulse. The glucose is controlling.
It's getting stronger. Take good pulse in, pulse in. Now get in the water. You swallow a lot of water, okay? Stay, just relax, mate, just relax. We're looking after you, okay? Understand? So strong heart, breathe now, strong heart. Just keep your head there, mate, it's okay. It's okay, it's okay. It's okay, mate, just relax, just take it easy. Where's all of it, mate? Good work. Well, where's mate? No?
As they wait for an ambulance, lifeguards try and piece together the events that almost killed Tucker.
What happened to him?
I don't know, I love to swim in the water.
No one knows how long Tucker was clinically dead in the water, but for 5 minutes, the lifeguards kept him alive on the sand. Despite the trauma of a major medical emergency, Tucker knows who and where he is.
What's your name?
Is it? How are you, Tucker? Where are you?
A shot of Maxillin will help stabilize Tucker. Lifeguards and paramedics brace him on a spinal board.
1, 2, 3, go.
They're concerned Tucker may also be suffering a spinal injury. Perhaps he was violently knocked out in the surf.
Was it immersion related or? I think so. He was found up the edge of the water. Pulled him out on the water. Have you used it on a rest before?
Oh, yes, we had 12 last year.
Did you?
Yeah. I don't really think it's unbelievable.
Oh, it's got to have someone behind it, mate. Oh, yeah. So you guys did all right.
Tucker's
Got a break, be back at 10 minutes after 8, ready to go into teams.